begin tonight's webinar with the AO Spine. So I want to welcome everybody and all the participants and fellows that are joining us tonight. I want to first and foremost thank the AO for allowing the University of Maryland and our fellows to participate in tonight's webinar. And essentially the topics that we're going to be discussing is one that's common to everybody that's been on the call during your training or your fellowship. I'm sure you've all been exposed to interbody fusions for degenerative conditions of the lumbar spine. And really what we're hoping to take home with the case review and the literature review is to better understand what that role is in your armamentarium for our patients. Now, over the past 10 to 15 years of doing spine surgery, as you're going to learn, there's been an onslaught of different approaches for the treatment of degenerative conditions and disorders of the spine. And obviously these include the role for an interbody device. When we think about interbody devices at Maryland, and most of you should all go through this thinking process, is the role for interbody to enhance the fusion? Is the role of the interbody to enhance the decompression or do an indirect decompression? Is the role of the interbody to help with deformity correction, or for all of them? We'll go through case examples tonight that hopefully elucidates and clarifies some of the situations when there is a role for interbody. You know, the technology advances. It is abundant out there. There are many choices and there are many approaches for interbody. There's T-lift, there's PLIF, there's O-lift, there's A-lift, there's lateral, there's X-lift, there's prone lateral, there's open techniques, there are MIS techniques. But what you need to understand is before you say, I'm going to do an interbody, you need to take 2 steps back. You need to think about the additional steps of doing the interbody. Does it make my procedure any better? Does it allow me to achieve my operative goals? Is the increased burden on me and the patient deserving? Is the economics value the situation? Are my outcomes better? I think all those questions and concerns need to be addressed when your decision-making for doing an interbody comes to play. So with that said, let's jump into this. Alex, can you advance the next slide, please? So this is our Division of Orthopedics, University of Maryland. Some of them will not be able to join for various reasons, but we want to thank everybody for being on. The highlight of tonight are our 3 spine fellows, Dr. Hamber Zumanian, Dr. Renahan, and Dr. Yunus, who will be doing the presentations. Dr. Ko will be manning the chat. Can you go on to the next slide? So any questions, you know, you can go into the Q&A forum. These are our disclosures that were all resolved prior to the webinar. Alex, if you can go to the next slide. I need to read this as part of the webinar that the AO North American staff involved in this webinar has no financial relationships to disclose other than what we just showed. The AO North America greatly acknowledges funding for all of its educational activities from the AO Foundation, and the AO Foundation receives funding for education through the Synthes grant. All rights for the educational resources, the assets used and owned by AO North America and the AO Foundation, and all its contributors are for educational purposes only. If you go to the next slide. AO North America, just so everybody understands, is an independent nonprofit surgical subspecialty society that's dedicated to improving the care of patients with musculoskeletal injuries. It does not endorse nor promote the use of any products nor any service of commercial entities. The equipment that you'll see in the cases in the webinar is for demonstration and teaching purposes only, with the sole intent for enhancing your learning experience. Next slide. I know most of you have been part of the Zoom meetings. All of your microphones, Chris Riley, has been muted and your videos are turned off. all your Q&As, all your questions should be sent through the Q&A channel. The chat is just for the faculty and the fellows that are running the webinar. Next slide. At the end, the objectives are much that I alluded to. We're going to discuss the indications for interbody fusions for degenerative lumbar conditions. We're going to describe the different approaches that I alluded to, and we're going to talk also about complications related to those approaches. Next slide. This is the overall agenda. We're going to go over 3 cases. The first case is Dr. Hamber-Zumin, who is going to be discussing degenerative spondylolisthesis and the role for interbody. Dr. Renahan will be discussing adjacent segment disease, and Dr. Yunus will be describing the role of interbody for adult degenerative scoliosis. We'll then have a Q&A to answer any questions that the audience has, and then we'll be done in about an hour. So once again, thank you for joining us. We really appreciate the AO allowing us to do this, and I'm gonna let Vachi start the first case. Vachi?
Thanks, Dr. Ludwig. It's a pleasure to have this presentation here. Thank you. So I'm going to start with a case of 63 years old female who presents with 1 year of back pain, progressive worsening in the last 3 months. She's having bilateral lower extremity radiculopathy, right more than left. Her pain is 50% axial, 50% appendicular. She's having subjective weakness in right lower extremity. Her treatment up to date were motoring and physical therapy. Her past surgical history is significant for L4, L5 hemi-laminectomy in 2012, then revision on the same level in 2018. Her past medical history is non-contributory. She's non-smoker and employed teacher. Next slide, please. These are her x-rays. And the next slide, please. MRIs. Next slide. And parasagittal views for the right and for the left. Next slide, please. As you mentioned, we're going to discuss here a condition which is well known to all of us, lumbar spondylolisthesis, lumbar spondylolisthesis, and the surgical options available, and namely the use of interbody fusion. Evolution for there has been evolution of treatment strategies for lumbar spondylolisthesis over the past few decades, from non-surgical to surgical, and when we are talking about the surgery, it has been changed from simple decompression to decompression and fusion, and when we are talking about fusion, it has been gradually evaluated and became more comprehensive, from posterior lateral fusion to interbody fusion and combined fusion. And there were several questions which have been answered during these decades, and still some questions which needs to be answered. And next slide, please. And one of the first question was it better surgical or non-surgical treatment? So this is a study from very famous sports trial published in 2009 in GPGS. And in this study, authors concluded that those patients with lumbar degenerative spondylolisthesis treated surgically, they did much better in 4 years, and they maintained substantially greater pain relief and improvement when compared with non-surgical treatment. Next slide, please. This is another study, randomized controlled trial published in a New England Journal of Medicine. And here authors comparing laminectomy alone versus laminectomy and fusion. And here they concluded that patients who had fusion have a clinically meaningful improvement in overall physical health related quality. Next slide, please. So in the case of degenerative spondylolisthesis, some of the questions got answers. We got answered some of the questions, namely surgery is better than a non-surgical management in degenerative spondylolisthesis associated with lumbar stenosis and foraminal disease, and fusion yields better long-term results. However, there are some questions which needs to be addressed, and this we're going to discuss now. And first, what is the best fusion and what is the best approach? Next slide. In this study published in Spine in 2009, authors compared the fusion method, and they asked a simple question: does a fusion method matter? So they compared posterior lateral fusion in situ, posterior lateral instrumented fusion with pedicle screws, and pedicle screws with interbody fusion, so-called 360-degree fusions. And they concluded that in patients with Degenerative spondy associated with spinal stenosis, there is no consistent difference in clinical outcomes among fusion groups. Next slide. Here comes the main question of today's discussion. Interbody cages, do they make a difference? If they make a difference, is it a radiological or truly clinical improvement? We all know that TLIF is one of the most popular surgical procedures. Next slide. And here's a study where authors comparing posterior lateral fusion versus TLIF. They analyzed 24 patients with TLIF and 32 patients with simple posterior lateral fusion. And they found no difference in lordosis of pelvic parameters, no difference in EBL or adjacent segment degeneration. TLIF yield better fusion rate in comparison with posterior lateral fusion alone. They concluded that TLIF has better results while restoring the disc height and might provide better improvement of leg pain. However, the overall health-related outcomes were not significantly different in two groups for both procedures. Next slide, please. This is another study comparing the same TLIF versus posterior lateral fusion, almost more than 100%, and results were that they are mostly similar in two groups. However, TLIF had a greater improvement in ODI scores at 12 months, and also authors noticed that TLIF really understandably increasing the hospital costs. Next slide. Again, a study comparing posterior lateral fusion alone with interbody. Here, authors concluded that there are no significant differences between two groups. The only thing that interbody devices, they are adding cost while producing no better results. Next, please. In this study, authors comparing posterior lateral fusion and PLIF. Now, instead of TLIF, we are dealing with PLIF, and there is no difference again. There was no surgical significant statistical difference in clinical and functional outcomes in both groups. Posterior lateral fusion showed more complication related to hardware, and it has inferior fusion than a PLIF group. So PLIF demonstrated better fusion. Next. How about minimally invasive procedures? We know that minimally invasive procedures, they are getting more and more popular. Does it make any difference? Does the approach make difference? This is another question which authors try to address in this study. They compared 100 patients with MIS TLIF versus open TLIF. And understandably, MIS resulted in reduced blood loss, less hospital stay, and faster return to the work. However, they have similar surgical morbidity, hospital readmission, and short and long-term clinical outcomes. Next slide. Does the approach matter? So to Dr. Ludwig's point, there are many approaches, TLIF, PLIF, lateral, with MIS techniques getting more and more popular. Next. So I just brought this study showing that minimally minimal approach, minimally invasive lateral interbody fusion is a safe and effective procedure for grade 2 spondylolisthesis. Here, authors analyzed 63 patients, and their results at 1 year were comparable with the results of other procedures for lumbar degen spondy. Next slide. This is a comparative study published in Spine in 2016, where authors are comparing MIS-TLIF versus trans-psoas approach. And authors are noticing that those are two different mechanisms. However, both groups experienced a significant pain relief and maintained clinical improvement with high fusion rate in 2 years. And conclusion is here that probably the mechanism of correction may not be critical, and both minimal invasive procedures are reasonable treatment options. Next. How about PLIF versus trans-psoas approach? This was another comparative study. Authors concluded that the restoration of disc height, foraminal height, and segmental lumbar lordosis restoration was significantly better in lateral lumbar interbody fusion group. The duration of surgery were similar. Blood was significantly lower in lateral approach, and clinical outcomes were similar in both groups. Next. So I brought this study just as a summary of presentation of my presentation. This was a study published in AO Global Journal in Spine. It's pretty recent in 2019. And the conclusion is that both minimally invasive and open surgical options are valid, they are available, and they are able to accomplish an interbody fusion. And at this point of time, literature does not support a clear benefit of one technique over the other. Next slide. And a few words about the complication. Here, this retrospective study, level 3 evidence, authors analyzed more than 13,000 patients, which were exactly matched, and they concluded that on the single level fusion, posterior lateral fusion alone or interbody fusion alone are associated with less complication that both procedure combined. Next slide. Again, this is any comments before I go to the post-op x-rays?
Yeah, Vaj, great job. You know, I think degenerative spondylolisthesis is probably one of the most common disorders that everybody will see, right, on a day-to-day basis. And it's probably one of the most written about disorders, but yet, as you pointed out very astutely, you know, there's no definitive data out there to suggest that the gold standard for the treatment of a degenerative spondylolisthesis, which is a common issue, the interbody fusion matters, right? So you really have to sort of think about, if there's no difference in outcomes, right? If it adds expense to your procedure, it adds time to your procedure, right? The true value in, you know, in the aid for our patients. So maybe, Eugene, what are your thoughts? When in the face of a degenerative spondylolisthesis, do you think there's value for an interbody?
I think there's two things that I always consider with an interbody is foraminal stenosis. Am I able to decompress it enough? And if the disc height is decent enough, then I might not necessarily need to do an interbody. The disc space is collapsed. I'll probably do an interbody for it to give me not only a direct decompression while I do a laminectomy and foraminotomies, but to also increase the height, to give me an indirect decompression. I'll also use it in the second instance if I have a poor host. So considering a diabetic potential ex-smoker or one that who's actively smoking may consider using an interbody.
Yeah, so all great points. So patients that are poor hosts, right, poor fusion hosts may benefit because we know, based upon a lot of the articles that Vachi have brought up, we know that achieving a fusion is important to getting a good outcome, right? So we know fusion patients for degenerative spondylolisthesis do better long-term, and the sport trial goes on beyond 8 years now in terms of the outcome. The fusion patients do better than the non-fusion patients. So poor hosts, right? I think it does make sense, Eugene, for adding an interbody in somebody that's compromised. Patients that have severe foraminal stenosis and severe, foraminal disease may benefit from that decompressive procedure through the interbody space that Dr. Ko was talking about. Additionally, patients that are deformed through their listhesis, that have a kyphosis through their listhesis, or that are hypermobile, right, on flexion extension views, have a lot of mobility, may benefit as well. Any questions, Eugene, from the Q&A that we need to review for this case?
Yes, Steve, we have 2 questions. The first question was actually looking at the 2009 study, looking at the 3 different cohorts. That's the study that talked about T-lifts versus non-instrumented fusions. And the question was, what were the cohorts consisting of? Were they identical in terms of their grade of their spondylolisthesis, and et cetera? And that's one of the questions that got answered. The second question is, do we use BMP2 in the posterolateral gutters for spondylolisthesis?
Yeah, so with regards to the first question, that data, and Vachi, correct me if I'm wrong, that was from the sport trial data, where the fusion patients were not necessarily matched based upon radiographic parameters, the degree of spondylolisthesis, the severity. I think much to, it's a very astute question, but it was not a matched cohort analysis, right? It was more of a potpourri of the surgeons, based upon their own internal biases, saying, for this spondylolisthesis, I'm going to do an interbody. For this one, I'm not going to do an interbody. For this one, I'm going to do a posterolateral and an interbody. So it's a really, really good, important point. I think, Vachi, is that correct?
Yes, that's correct. Yeah, they were not matched. They just surgeons, they chose according to their indications, and they were not matched. No.
Yeah, I almost never use BMP, Eugene, for my interbodies or posterolaterals. I'm using, my choice of bone graft is typically local bone that I harvest from the facetectomy and the laminectomy, that I put in the cage and put in the posterolateral gutter. If I need to augment it, I typically use crushed cancellous bone with a demineralized bone matrix product to act as a graft extender. I don't know. What are your thoughts on BMP?
Yeah, I think you, at least when I discuss BMP with, usually with patients of poor hosts like smokers or diabetic, I'll actually kind of discuss a little about what we know about the risks and benefits of BMP2. This question was specifically, if we don't use interbodies, do we use BMP2 in the posterolateral gutters? I typically don't. I'll use local bone as well as demineralized bone matrix to extend it and see how they do. If it's a revision that needs to get addressed, then I think, and they have a pseudo, then I'll consider using BMP2.
Got it. So, Bach, show us what you guys did, and then we'll move on to the next case.
Sure. Next slide. This is what we did. Simple decompression, revision decompression with a fusion, posterior lateral fusion.
So understanding when not to do an interbody, I think, is just as important as understanding when to do an interbody. I think that was the point why you picked this case. But
yes, yes, exactly,
yeah,
absolutely.
This case illustrates, a good host, essentially, somebody that does not have a hypermobile spondylolisthesis, somebody that is not a kyphotic through their disc space. I think somebody, based upon their foraminal disease, as Dr. Ko pointed out, doesn't have that severe foraminal stenosis and doesn't have that collapsed disc space, like Dr. Ko pointed out, that needs that that additional indirect opening up of the foraminal zone for the L4 nerve root. So, so that case once again illustrates in a very common patient population that you don't always have to do interbodies for all these folks. So I think that was the teaching point for this case. So let's move on to the next slide. Alex and Jack, are you on and take over the presentation?
Yeah, thanks, Dr. Lowig. So I'm going to go and I'm going to talk about adjacent segment disease and the use of interbodies for that, in particular, the use of lateral interbody cages. So our case is going to be a 51-year-old female. She's presenting with lower back and then left greater than right leg pain, primarily on the anterior thigh. She's had this pain for a long time, over the last 9 months. She's done all sorts of non-operative treatment and is kind of at the end of the road and here to discuss surgery. She's currently taking a number of medications. Those aren't working either. No new numbness or weakness, but she does have some left lateral foot numbness that did not completely resolve after her initial decompression and fusion. And she had an L4, L5 a few years ago. I can go to the next slide, please. So she's got a pretty benign medical history, but she does have a significant surgical history for hysterectomy and a lap chole in the past, and then a couple of other orthopedic, just an RAF of her tibia. On physical exam, she's in pretty good shape. She's got good alignment. Her strength is good. She just has that residual numbness on her left L5 nerve root. And then she really just traces the pain without numbness or weakness on the left L3 dermatome. Next slide, please, Alex. So this was the imaging after her initial index surgery, the 4-5 Lami fusion back in 2019. You can see she's got good disc height at L3, L4. Good lumbar lordosis, overall really excellent radiographic outcome with a good laminectomy defect, good adequate decompression. You can go to the next slide. So this is her x-rays when she presented to us. You can see she still has a good patent laminectomy, but there's some interval changes at L3, L4. There's a low-grade spondylolisthesis, a little bit of loss of disc height, and you can see there's just some general facet arthropathy proximal to the fusion construct. So this is already concerning for adjacent segment disease. We can go to the MRI next, please. So this is at L3, L4. And you can see there's significant facet arthropathy here with gapping of the facet joints bilaterally, significant abnormal fluid signal. And you can see she's got foraminal stenosis there, a little bit in the recess, but primarily foraminal stenosis. Otherwise, pretty benign findings. It's just that focal pathology there. And I think, do we have the parasagittals, Alex, next? Yeah, so you can see this is on the left side. You can see she's got that foraminal stenosis. If you compare it to L2, L3, and L4, L5, it's significantly narrowed. And that seems to be the target of where she's having most of her symptoms. Next slide, please. And on the right side, you can see similar pathology, but obviously she's not symptomatic here as much. Next slide. So in the assessment, as we discussed, she's got a status post 4-5 Lami fusion. But she's developed foraminal stenosis with adjacent segment disease at 3-4 above her fusion. She's symptomatic. She's failed non-operative treatment. So next slide. So there's a couple of studies, and there's not really good high-powered randomized trials looking at the specific problem. It's something that's been treated with interbody fusions because the data has not been around that long to really generate it. But there was one interesting study that I found that looks specifically at this, and it was comparing lateral MIS lateral interbody fusions to standard posterior interbody fusions for this condition. And what they did is a little bit different from I think what we would do in the States, but they just had a change in practice, 40 patients, and they switched over and then matched 40 patients starting a new year, and they just compared them. And what they would do is they would just do a standard posterior approach, open fusion, open interbody cage for the previous patient cohort. And then when they matched it, they would just do an MIS lateral interbody, actually close them up, admit them to the hospital, and then they would get an MRI looking at their parameters in their canal at the level of their indirect decompression. And then the surgeon then determined whether the indirect decompression was adequate enough to proceed with just a standard open fusion posteriorly, or proceed with doing a direct decompression as well. And they found that about half of the cases, about 0.6, 60% of the time, the indirect decompression was adequate radiographically. Now, this was not based off of patient's symptoms. This was only about 4 to 6 days post-op, but they would then determine based on the MRI to go back and either do an open decompression or just an open fusion without the decompression. And what they found was based off of these two things, really the only difference between the two was whether they got a lateral cage or a posterior cage. And in looking at the lordosis, there was a substantial improvement relative. I mean, substantial may be the strong word. It's 2 degrees better on the lateral X-ray, but there was a much improved central canal diameter in the indirect decompression group that probably was, we don't have a direct threshold of when someone suddenly in this specific setting doesn't need a direct decompression, but you can see across the board, they did have a substantial improvement in their canal diameter, also an improvement in the foraminal height with the lateral interbodies. In both groups, they improved significantly, but in the MIS lateral interbody group, at 3 months, they were doing better all the way up until 3 months. And then things started to equilibrate a little bit. And after that, things were pretty much the same. But you can see this was one of the MRIs that they obtained in one of these patients after the initial stage of the surgery, after the lumbar or the lateral fusion. And you can just see here, without any direct decompression, without anything, the canal has substantially opened up, decompressed the lateral recesses and the foramina. You can see here in figure B that foramen has a significant amount of epidural fat that's now visible around the nerve root. You can go to the next slide. And then these are their tracking their outcome scores post-op. And you can see they essentially become clinically, statistically insignificant. The two, really the major difference between these two groups was operative time between the posterior and the lateral. And obviously the lateral interbodies took a lot longer because they had to do 2-position surgery in this case. But, compared to those two, not a significant difference in any other demographic or feature. And so you could argue that it's in many cases it allows you to avoid the direct decompression and the operative time associated with it. And I think you could even argue that in this case, they probably did some unnecessary direct decompressions because they didn't really have a set threshold of when they were going to do it. It was just surgeon's discretion. Next slide. So then the other study, this was out of New York. It was a 2-center study between HSS and Cornell. And what they were looking at specifically was, does the type of construct in an adjacent segment scenario matter? And I think we all understand, even in the cervical, the lumbar literature, that adjacent segment disease is not native virgin spine. This is spine that's been operated on, and there's a stress riser that's going to change the biomechanics and the healing environment at that adjacent level. That's why it's gotten degenerative in the first place, and that's why you may have to do particular attention in order to getting that fusion to be successful. So they looked at 52 patients at these 2 centers, and all they did was a single level lateral interbody fusion at that adjacent level. And they found significant reductions in leg pain, patient outcome scores. They improved the lordosis. There's also a significant improvement in the coronal imbalance. So sometimes patients had an asymmetric foraminal stenosis, and that was improved. The foraminal height improved significantly. So radiographically and for patient outcomes, for the most part, things looked very good. But there was kind of one exception, is the reoperation rate. And they said, well, why do these patients need a reoperation for their lateral interbody adjacent segment surgery? And a lot of the times it was patients who had just had a standalone cage. And the caveat to that is that did not include patients who had a lateral plate. They either had a standalone cage without any posterior fixation, or they had a lateral cage with posterior fixation. In the majority of the cases that had symptomatic pseudoarthrosis with adjacent segment disease that did not resolve, those are patients that had a standalone cage. So their conclusion based off of this was, while it seems that lateral interbody fusion is a successful and reliable way to treat adjacent segment disease, you have to be careful in that the biologic environment is not amenable to successful radiographic fusion. So only 50% of standalone cages achieved radiographic fusion on CT. How many of these patients were symptomatic was a much lower number, but certainly that increased the risk of revision surgery and essentially failure of their symptoms to stay resolved and return of their symptoms. So their conclusion based off of this series was they recommended to consider 360-degree fixation for adjacent segment environments. Next slide. And so this is again, the index radiographs. You can go to the next. And I put a number of different options, if only, as Dr. Ludwig had alluded to at the beginning of our talk today, there are so many different ways that you can treat this, whether you're doing open, whether you're doing MIS, whether you're doing posterior fixation, whether you're doing lateral, posterior cages. There's a whole lot of different options, but it certainly seems that I think one thing to consider is that the biology in lumbar adjacent segment disease is not ideal. And certainly in patients with poor host biology, considering a more robust fusion construct is wise, and also that you can reliably achieve good indirect decompression in foraminal and recessed stenosis.
Yeah, Jack, why don't you put up the procedure that you did for this case? I think this is a really great discussion points, Jack, and great articles that you brought up. I think, the issue with adjacent segment disease is it's very common for a lot of different reasons, right? It occurs for a lot of different reasons, and that's a webinar in and of itself. But we have to decide for our patients what's best for them, right? Do we do an open revision, surgical decompression, infusion, add on to their hardware, the morbidity of the blood loss, the length of stay, the transfusions, the discomfort and pain, right? And the costs involved with that? Or are these minimally invasive approaches that Jack brought up, or the lateral-based approaches, a viable option, which I think there is compelling data to suggest that it's not superior, but it is a viable option. And it may be superior depending upon what metric you look at. I think when you show the final x-rays, Jack, and you had done for this low-grade spondylolisthesis with a L3 radiculopathy, you did a lateral-based approach in her, and to your last point, you added some form of mechanical fixation, which is important, right? Because if you believe that getting a fusion is important, and you believe that stability in order to get a fusion is important, and you want to avoid the morbidity of going in the back and adding on to your posterior fixation, then adding some form of fixation in the place, you chose a plate. Your x-rays look great, right? As a means of achieving your goals, getting the patient out of the hospital as a day-stay procedure, avoiding the blood loss associated with a posterior approach, and the length of stay and the morbidity. I think this really becomes, achieving all your goals and a viable option. I guess, Eugene, any thoughts on this? How much stenosis is too much for indirect in your mind? Does the levels matter, right? This is the L3-4 level in terms of fixation and mechanics. Does it matter if it's 4-5 for an adjacent segment versus 3-4 versus 2-3, 1-2? Does that change your mind? Bone quality, does that play a role? This is a female, Jack, I think you said, right? Did you get a DEXA, Jack, in her? Did you know if she had any history of osteoporosis or penia?
I don't believe there was a DEXA scan. I think we based it off her age. She was only 51. I think we just deemed that we didn't think that she was at high risk for that, especially with her successful
You can use Hounsfield units, right, for assessing bone quality on CT as well. But Eugene, what are your thoughts on this? How much stenosis is too much when you say I can't do it for adjacent level? Is this just your ridiculous option in your mind? How does osteoporosis and the level play a role? What are your thoughts on this?
Yeah, I think there's all good considerations. If there's a lot of significant central stenosis and they have neurogenic claudication rather than just simple lumbar radiculopathy, then I probably would approach it with a direct decompression. to address the central stenosis and their neurogenic claudication. I think this is great for foraminal stenosis. I think the levels do matter, and the body habitus of where you can position it. I think these lateral-based approaches are great at L2-3 and L3-4. L4-5, I have a hard time sometimes dealing with the instrumentation because you're dealing with the iliac crest. You're also dealing with a lumbar plexus at that time, and to map out specifically and not bugger up the lumbar plexus, I think it gets tricky around L4-5. So I think it's great at L2-3 and 3-4. Great question about osteoporosis. If it is osteoporosis, I probably would do a cage and then back it up posteriorly. I don't necessarily trust the standalone cages. I think you can get some subsidence. I also get concerned about doing a cage and a plate in osteoporotic bone. One of the questions that we had answered, or one of the questions that got brought up in our question and answer session is, do we consider a cage and lateral plate equivalent to a cage with pedicle screws? What's the comment and thought about that?
Yeah, I think our group did a study, as you probably remember, Mark Shasty's data that's published, looking at that exact question, right? Is a plate good enough? So in the face of non-osteoporotic bone, in the face of normal bone quality, you can, in the mechanics for lateral interbody fusion, with the exception of lateral bending, I believe, and rotation, the mechanics are fairly equivalent. You know, and it's almost irrelevant if you're at L1, 2, or 2, 3, but it becomes more relevant as you go down the spine and those motion segments become more important with regards to your range of motion. So I would say in the face of a normal non-osteoporotic spine, you know, doing an adjacent segment construct like Jack had done and brought up here makes sense. However, to your point, astutely, Eugene, in the face of osteoporosis, you know, if you're going to do an interbody because the posterolateral fusion bed is compromised and it's a more challenging, harsher fusion environment, the patient is osteopenic or porotic, and you need to enhance the ability of the spine to fuse, I would do an interbody, probably through a posterior approach or a TLIF approach, or even a prone, you know, lateral-based approach as well that I think we're going to talk about next, maybe an option as well, but I would add pedicle screws. So I think bone quality and the level of the spine, you know, plays a role in the decision-making. Any other thoughts, Eugene, or?
Yeah, I think I've got into trouble with interbodies when you're trying to do coronal correction in the presence of osteopenic or osteoporotic bone and relying on the interbodies to correct it. Focally, a coronal imbalance. I think you know, if it's osteoporotic bone and osteopenic bone, I've gotten a lot of subsidence when I've done that. So I think you just got to be careful on how much correction you get coronally. Although you know, these are great interbodies to get coronal correction, just be careful with osteoporotic and osteopenic bone.
Good point. All right, well, thanks, Jack. Great case, great articles, great points you brought up. Manaf, do you want to move on to the last case?
Yes, thank you very much. Next slide. Well, I'm going to present a 68-year-old lady who presented with several years of low back pain, with 6 months of progressively worsening pain with right lower extremity radiculopathy. She received multiple transforaminal steroid injections, which provided only transient relief, and taken tramadol, meloxicam to control her pain. On examination, she had diffuse paraspinal muscle tenderness, intact motor and sensory exam, no hyperreflexia, negative straight leg raising. We noted a curvature throughout her lower back. Her coronal and sagittal balance were normal. Next slide, please. This slide shows the radiographs of this lady at presentation. The AP radiograph is showing a right coronal lumbar curve. and the lateral X-ray showing satisfactory alignment with no signs of instability. Next, please. The MRI demonstrated the degenerative scoliosis, namely from L3 to L5, with some collapse at L3-4. Next, please. The axial views shows severe L4 foraminal stenosis and lateral recess stenosis. Next, please. So the L5-S1 disc space is the most common site of pseudoarthrosis in scoliosis correction surgery. For this reason, interbody fusion at L5-S1 is commonly performed in adult degenerative scoliosis via anterior or posterior approaches. Interbody placement can potentially increase fusion rates because it completes a circumferential 360-degree fusion at that level, decreases stress on the pedicle screws, and increases lordosis. Next, please. While many studies have examined factors such as foraminal height, disc height, segmental angle, pelvic parameters with interbody placements, few studies have focused on the difference in fusion rates between anterior and posterior approaches. So in this study, Sushiya et al. Showed that in adult degenerative scoliosis, adding an interbody support increased L5-S1 fusion rate to 95% versus only 83% without interbody support. Due to the long follow-up with minimum of 5 years and relatively large sample size in this study, this has contributed to the evolution of using interbody fusion more often in deformity surgeries. Next, please. Zimmerman et al. Reported on a total of 35 patients with adult scoliosis. 16 of them received only posterior spinal fusion. A complication rate of 49% was reported at 2 years of follow-up, 26 of which were major complications. The study reported statistically significant improvement in ODI, and short form 36 physical and mental outcomes showed improvement of 13.7% and 16.2% preoperatively to postoperatively. Next, please. Well, traditionally, anterior spinal fusion with instrumentation of lumbar or thoracolumbar curves was most common, as it provided excellent deformity correction and high patient satisfaction. Crandall and Rivea compared ALIF to posterior lumbar interbody fusion in the treatment of degenerative lumbar scoliosis. They reported no significant difference in clinical outcomes or complication rates. Radiographic outcomes among both ALIF and PLIF were similar, as well as patient-reported VAS and ODI outcomes. Next, please. Kim et al. Retrospectively reported on the associated complications and patient satisfaction rates of 62 patients with adult scoliosis who underwent anterior thoracolumbar approach for treatment of their deformity. The study reported 82% satisfaction rate, but many patients reported dissatisfaction in regarding of their anterior incision, specifically related to pain over the scar area and bulging appearance. Patients also reported functional disturbances with their daily activities as a result of their anterior incision. Next, please. Posterior approaches in treating adult lumbar spine deformity have been the mainstay for the surgical treatment for quite some time. These includes PLIF and TLIF in conjunction with posterior instrumentation. In this paper, Bernstein et al. Suggested that TLIF was an effective treatment for scoliosis, but can be accompanied by high complication rate. Their study reported improvement in patient-reported outcomes and radiographic improvements among the 29 patients. However, the study reported high complication rate of 31% for systemic complications, 49% for hardware or surgery-related complications, and a revision rate of 28%. Next, please. Correction with TLIF was 10 degrees per level in the coronal plane and 6.8 degrees per level in the sagittal plane. This data suggests that this surgical procedure can result in good coronal correction, but it's not the best for sagittal correction. Regarding segmental sagittal correction, the TLIF is limited because the insertion of a large intervertebral fusion cage is impossible with the small poro to the disc space. Next, please. Lee et al. Retrospectively reported on 46 patients who underwent TLIF for the treatment of degenerative scoliosis. The correction rate in this study was reported as 67% for Cobb angles, 44% for the mean lordosis angles, and 80% for the mean segmental lordosis angle. This study also reported a satisfaction rate of 81%. Next, please. In a study of a total of 198 patients, TLIF performed in 133 and ALIF in 65 patients who underwent long segment fusion to the sacrum with iliac fixation for adult degenerative scoliosis. Although both ALIF and TLIF procedures at the caudal level of long spinal deformity constructs achieved similar and satisfactory deformity correction, ALIFs were associated with a lower rod fracture incidence rate than TLIF. Next, please. A recent multicenter study by Buell et al. Investigating the operative treatment of adult symptomatic lumbar scoliosis with L4 to S1 TLIF versus ALIF demonstrated also comparable mean fractional curve correction despite the use of significantly larger, more lordotic ALIF cages. TLIF cage height had significant impact on leveling of L4 coronal tilt, whereas ALIF cage lordosis had significant impact on restoration of the lumbar sacral lordosis. The advantages of TLIF may include reduced operative duration and hospitalization. However, the HRQL was inferior and more rod fractures were detected with TLIF patients included in this study. Next, please. In a retrospective study of 53 patients with ALIF with posterolateral fusion patients and 110 TLIF patients demonstrated that TLIF has shorter operative time, lesser blood loss, shorter hospital stay, and lower complication rates, 51% in anterior posterior fusion versus only 28% in TLIFs. Pseudoarthrosis, wound infection, and radiculopathy were the most common frequent complications in this study. Next, please. Mondes et al. Conducted a literature review of the lateral approach, suggesting significant improvements in the VAS score and ODI score, and degrees of coronal and sagittal correction, and decreased blood loss, shortened hospital stay in comparison with the open anterior procedures. The literature did reflect different complication rate. However, major complications were low, and most studies cited a transient motor deficit, but reported resolution at subsequent follow-up visits. Next, please. Isaac et al. Reported 12% major complication rate, similar to that reported in the literature, among 107 patients who underwent lateral interbody fusion for the treatment of adult scoliosis. Next, please. However, the lateral approach has its own potential complications, as I said, mostly related to the manipulation of lumbar plexus. Tormenti et al. Cited a high curve correction of 70% in patients who underwent a combined lateral transpsoas and posterior approach compared with 44% with patients who underwent posterior approach only. However, 6 of the patients with combined approach reported postoperative thigh paresthesia or dysphagia, and 2 demonstrated sustained motor radiculopathy, all of which resolved at 10 months postoperatively. Patients Patient-reported VAS score were similar in both groups. Next, please. Wang and Momanini retrospectively demonstrated a 97% fusion rate at treated levels and 20-degree coronal balance correction in 23 patients who underwent lateral interbody fusion with posterior pedicle instrumentation. Next, please. Dakwar et al. Reported on a total of 25 patients, 8 of whom received lateral interbody fusion with posterior pedicle screw instrumentation, and 15 received lateral plates. At 1-year follow-up, the study reported improved VAS scores by an average of 5 points, ODI scores by 23%. Postoperatively, only 12% were found to have sensory deficits that resolved by 3 months follow-up, as previous studies have demonstrated. In regards to correction, one-third of the patients in the study did not demonstrate the correction of the sagittal balance. However, 80% of patients at 6 months postoperatively had demonstrated solid fusion. Their study determined that lateral interbody fusion with or without posterior instrumentation is reasonable alternative to other anterior and posterior approaches to correct adult degenerative deformities. Next, please. A recent study comparing lateral lumbar interbody fusion and posterior lumbar interbody fusion in patients with adult spine deformity demonstrated that all radiographic parameters significantly improved in both groups at the final follow-up. The comparison between both groups demonstrated no significant difference in terms of postoperative pelvic tilt, lumbar lordosis, PILL mismatch at the final follow-up. However, the sagittal vertical axis tended to be smaller in lateral lumbar interbody fusion at the final follow-up. Overall, the perioperative and late complications were comparable in both procedures. However, the LLIF procedure demonstrated significantly less blood loss and smaller incidence of postoperative epidural hematoma compared with PLIF or TLIF procedures. Next, please. A single institution retrospective review of patients treated for scoliosis concluded that more levels of interbody fusion resulted in increased lordosis, increased scoliosis curve correction, and fractional curve correction. However, additional levels of interbody fusion up to 3 levels did not result in more postoperative complications or morbidity. ALIF resulted in a greater lumbar lordosis than TLIF, but ALIF had higher revision rate postoperatively. Next, please. Good et al. Retrospectively compared the clinical outcomes of 24 patients who underwent combined fusion with 24 patients who underwent a posterior-only approach at a minimum of 2-year follow-up. The study concluded that both groups demonstrated similar postoperative radiographic correction and alignment, along with no significant difference in postoperative complications. Despite the insignificant higher rates of pseudoarthrosis in the combined group, the patient-reported outcomes were similar and demonstrated significant improvement from baseline. Next, please. A combined approach is necessary for a larger degree of curvature along with coronal and sagittal imbalance. However, combined procedures can lead to increased operative time that can result in increased medical stress, leading to increased complications and morbidity rates. Despite the disadvantages of combined approach, literature demonstrates higher fusion rates, higher degree of deformity correction, and better overall patient-reported outcomes. Next, please. Now back to our case, our adult degenerative scoliosis. Again, these are the radiographs showing multi-level degenerative changes with lumbar curvature. Does anybody have any comments?
Yeah, man, a spectacular job. I mean, it's a tremendous effort reviewing the literature for patients with degenerative, scoliosis or deformity. And this, this is once again, this one case represents an entire webinar. As you pointed out, there's a lot of literature, and you astutely brought up a lot of the pertinent literature comparing anterior T-lift, PLIF, posterior directed approaches. So bravo for bringing all that stuff to light. I think this is a conundrum. You can show this case, and we can get 10 different approaches, right, to accomplish our goals. And I think the approach is really dependent upon what your goals are, the deformity, patient characteristics, previous surgery, what the surgeon and their technique and what works best in their hands. All that plays a role, right? Mm-hmm. Clearly, a lot of the literature you described suggests that a posterior directed approach with posterior decompression, instrumentation, fusion, open, T-lift or not, that can be fraught with a lot of potential blood loss, complication rates based upon age, deformity correction, number of levels, right? Significant morbidity, time in the hospital, cost, expense, with potential loss of outcomes. As opposed to some of the data that you brought up, showing that indirect decompression through a lateral-based approach, we know there's a treatment effect, right? We know there's data to support that indirect decompression in the right candidate, with the right curve, right, and the right indications, lateral-based approaches are a viable option, right? You clearly shown that it's faster in the OR, less EBL, less transfusion rates. Of course, it has its own set of complications that you brought up, but you can get significant deformity correction. You can get significant decompression, significant fusion rates, and achieve your operative goals. So show us what you did here, and then let's get some thoughts from Eugene about this. So what'd you end up doing here for this case?
So we performed lumbar interbody fusion through prone lateral transpsoas approach at L3-4 and L4-5 with posterior lateral fusion of L2 through L5.
Yep. So once again, this looks great radiographically. You corrected, your curve. You have excellent sagittal plane alignment. It would be nice to see some long-standing scoliosis views just to validate this. But there you go. Thank you. But you've achieved the goals of correction, alignment, decompression, and fusion as well. You did this through a prone lateral approach. Is that correct?
Yes, that's correct.
Lateral-based and then posterior-directed approach. So, Eugene, any thoughts on prone lateral versus lateral approach? I know people are interested in that approach as another potential interbody approach. Any thoughts on why going prone versus a typical lateral-based approach?
Yeah, I think with prone, the advantage of prone, it's single position. You can position the patient prone. You also get the curvature in your lower dose much better in a prone position rather than in a lateral decubitus position. Usually, if it's just a lateral, when I've done these on a lateral and then backed them up posteriorly, usually it's about a 30-minute turnaround time, undraping, repositioning the patient. So this is much faster doing it prone. Someone can close up the incision, the fellow can close up the incision as I'm exposing posteriorly. I think for me, as a teaching institution, doing a prone approach, we can actually, the fellow can see over my shoulders and look directly at what I'm looking at. When I've done it in a lateral decubitus position, both of our heads are bumping into a small tube that are looking at it. So I think in a teaching purpose, as well as a patient outcome, I've really enjoyed the prone lateral approach. Kind of changed my practice in the past 2 years doing more prone laterals.
So you like it because you think it's better for patients with regards to their alignment. It's better with regards to OR time because it's saving position. does the laterality of approach, when you're doing multiple levels, are you going all through one side, one incision? How do you determine that, the laterality of the approach? Have you ever done prone laterals on the right and the left simultaneously so you can do levels a little bit more efficiently? Do you have any experience with that?
Not done. Done multiple levels. Not done it on right and left side. I've usually applied it either on right or left, but never on bilateral approaches. The one thing that I've noticed about the lateral approach, a prone lateral approach, is your resistance against when you're putting the cage in. I notice that I have to use a much heavier force putting the cage in because I don't have the resistance. When I'm in a lateral decubitus position, I have resistance of the whole table that I'm putting the cage against. I've noticed that when I've done these in the prone lateral, I'm using a lot more force than I'm putting a cage in. So I'm not sure about doing a bilateral approach just to save time. I think for me right now, I'm still getting the logistics of it to work out perfectly. I just do it on one side. I'm not fancy enough to do it bilaterally.
Yeah. Some of the people that are championing this will tell you that having a contralateral bolster to prevent the patient from moving and the cage from bouncing back and the retractor shifting out is important. And I think you brought that up. Even tilting the patient obliquely so that you're working at a better angle from an ergonomic standpoint, and just from getting your surgical working zone and orientation a little bit more well oriented. I think the teaching purposes that you brought up are really important. I think the one thing that you have to be concerned about is migration of everything, because gravity sucks and everything sort of goes down to the ground. So you have to be careful with your retractor that you have it nicely anchored, with a good intradiscal sort of stability shim, so that you can do your intradiscal work effectively. I think that's important as well. But you really, once again, you have to master this technique in a lateral, gold standard technique before you move into that sort of prone, sort of more expert technique, just because it throws you off a little bit. But I think I'm glad, man, if you brought this case up. It illustrates sort of the value, to your point that you brought up, at interbodies. It brings up the value of maybe innovative techniques or MIS techniques in achieving those goals of surgery. So I think this is an interesting technique that probably, once again, is in this early adoption stage, and it's beginning to gain more and more popularity. So with that said, Eugene, do we have any other questions from the audience that have come up?
No other questions, Steve.
Okay. Well, with that said, guys, I want to once again thank AO for helping us sponsor today's webinar. I think the take-home points really are that you have to really take two steps back and think about what your goals of surgery are for that patient and for their underlying degenerative condition. I think you have to think about what the value of the interbody is for achieving those goals, right? Does it make the outcomes better? Does it improve my goals of the surgical procedure? Does it enhance my patient's recovery and outcomes? And does it bring financial value, right, to the procedure with all those improved outcomes at the increased cost? I think you have to consider that when you're making a decision. But at the end of the day, it has to be the right decision for the patient. So with that said, I want to thank everybody once again. Everybody have a great night, and we'll see you at the next webinar. Thank you so much.